The goal of this presentation is to share safe and effective ways to position and move your patients who are recovering from stroke. We will cover positioning in bed and in a chair, and safe rolling and transfer techniques. This knowledge will help you empower your patients to perform their daily activities safely. To begin, let's briefly review the anatomy of the shoulder. Here we see a part of the humerus, the upper arm, and the scapula, the shoulder blade. The head of the humerus sits in the shallow socket of the scapula. Together they form the shoulder joint. The scapula is not fixed in place. When the arm moves, the scapula normally moves with it. This is most clear in a young child. This simultaneous movement is crucial for a person to achieve full arm range of motion. It's important for reaching, for standing, and other basic movements. However, after a stroke, the scapula may no longer move with the arm. When it doesn't, patients will have limited ability to perform ADLs and may risk further shoulder injury. The shoulder is only held in place by muscle and soft tissue, as you see here. The shoulder joint has great mobility, but is also vulnerable to injury. After stroke, muscles become weakened and the humerus may easily dislodge from its socket. Along with muscle weakness, survivors of stroke have impaired sensation and low muscle tone. They have trouble moving and feeling their own bodies. They may need help holding themselves upright and maintaining proper alignment. Without that help, they may develop a host of secondary complications, including shoulder pain, subluxation, adhesive capsulitis, shoulder impingement, contractures, or shoulder hand syndrome. With proper handling, we can greatly decrease the risk of developing these problems. Remember that all our bones are connected, so the only way to maintain proper shoulder support is to make sure that the whole body is aligned correctly. Let's now look at some ways to assist these patients in maintaining proper alignment. This model is poorly positioned. Watch how the caregiver repositions her. First she moves the pelvis, then the torso, the head, the arm, and finally the wrist. Watch how the caregiver moves the pillow from behind the shoulder to under the forearm, generally reposition from the middle of the patient's body outward. Patients should be repositioned before any nursing task. Repositioning has many benefits for both you and your patient. It increases the comfort of your patients, makes them safer, eases movement for both of you, helps to prevent injury, and it makes your work more efficient. Here we see before and after pictures of our model. Clearly, before, her pelvis was rotated, her head was bent forward, her right shoulder was pushed up and forward by her supporting pillow, and her wrist was twisted. How often have we seen patients recovering from stroke in this position? Sensory loss in people after stroke is so common that they may not report discomfort even when they are poorly aligned. And even if she feels uncomfortable, your patient may not have the ability to change her position. People after stroke need help to adjust their bodies so that they maintain a safe and comfortable position. Let's take a closer look at that shoulder. Notice how the pillow is placed under her forearm, similar to an armrest on a chair. The goal here is to make sure that the shoulder is supported and that the arm sits in its socket. Once your patient is properly aligned, she is ready to be rolled. Watch as the model is asked to hold her own arm. We want to empower patients to participate in their own movement as much as possible. The caregiver places her hands on the two key points of control, the scapula and pelvis, as she rolls the model to the edge of the bed. The key points of control are important. They allow us to move patients with the most control and the least effort. For your patients, moving them at the scapula and pelvis allows for mobility without potential harm to their shoulder. By using the key points of control, we minimize risking injury to the affected arm. Here we see a picture of what not to do. Our caregiver is not using the key points of control. In fact, by pulling on the affected arm, she risks damaging the patient's shoulder and makes this task harder for herself. Let's watch again as the caregiver assists the model in holding her own arm. The caregiver supports the affected arm at the elbow as she instructs the model to hold it. The model will then replace the caregiver's hand with her own. As you see here, notice how the affected hand is resting on the supporting arm. Patients may forget to hold their arm as they are being moved. Don't hesitate to offer gentle reminders. We want our patients to hold their own arms, but we want to teach them not to pull, as this could lead to shoulder complications. Here we see the model pulling at her arm. Notice how her shoulder has shifted forward and her affected hand is dangling unsupported. When the affected arm is supported and not pulled, you will see that the hand rests by the crook of the opposite elbow. Sometimes patients have trouble holding their affected arms. Here we show you an easy way to roll your patient and support their arm using a bed pad. As you know, this method requires less effort, so it is easier on your body and better for your patient. The bed pad supports the arm so it doesn't fall back. Our model is now sitting at the edge of her bed waiting to transfer to her wheelchair. We want to put a support under her elbow so that gravity does not pull her arm down. We use a pillow like the armrest on a chair to provide that support. Here our model is positioned for a familiar transfer. Notice that the caregiver gives support in two crucial ways. Watch as she places her hand under the elbow as she removes the pillow. She keeps her hand there throughout the entire transfer, which prevents the affected arm from swinging out and getting injured. And it cues the model to continue holding her own arm. Now watch as she places her left hand over the scapula while she guides the model to the wheelchair. Remember, ensuring that the scapula moves in sync with the rest of the body is crucial to maintaining proper alignment, greater range of motion, and ease of movement. Sometimes you will see a patient sitting like this in a chair. Let's review how to realign them. Generally, start from the center of the body and move outward. First, adjust the pelvis, then the head, then the arm, and then the hand. This model is positioned well in her chair using two pillows. One supports the back without pushing her shoulders forward. The other is under the affected forearm. Another way to support the arm while seated is to use a lap tray. In this position, the patient can be encouraged to touch her affected hand and arm, even apply lotion, to stimulate sensation and increase awareness. In this presentation, we have discussed various ways to support patients after stroke. Let's review them now. Your patient's entire body should be realigned before any activity, generally starting from the center and moving outward. Your patient's shoulder can be supported in these four ways: by your hand at her scapula, a pillow at her elbow, your hand at her elbow, or her hand supporting her own elbow. Finally, by using the two key points of control, the scapula and the pelvis, we decrease the risk of injury to the affected arm while simultaneously making it safer and easier for us. We hope that this presentation will help you empower your patients to take proper care of their affected shoulder, to maintain and increase their independence, and facilitate their post-stroke recovery.